Good morning, everyone. Thank you for joining us this morning in our session, Progress Toward Prevention and Reversal of Type 1 Diabetes, with our presenter, Dr. Laura Jacobsen. We are very grateful that you are here with us this morning. Just very quickly, a few housekeeping reminders, both you'll get some in the beginning and at the end. There will be a Q&A at the end of the session for about 10 minutes or so. Just realizing that because this room does get utilized for lunch as well, we do have that hard stop at 12. Dr. Jacobsen did say that she would stick around afterwards to answer any questions if we don't get to them, whether it is in here, whether it is in the hallway, just so that way you have the opportunity to ask any questions that you do have. Just a reminder as well, if you are a parent to a child in elementary or kiddie cove, your child must be picked up from their sessions. As we've heard earlier, teens and tweens are released into the wild on their own, but you're responsible for your littles. We are very interested in feedback during these sessions. So as you can see at your tables, we do have surveys, as well as I think each table should have 1 or 2 pens. Feel free to fill it out as you are going along or just at the end of the session, but we will remind you of that as well. And then lastly, just that friendly reminder, masks are not required throughout the conference, but if you want to wear your mask, please feel comfortable. There is no problem with that. Otherwise, thank you again for being here, and thank you, Dr. Jacobsen.
All right, am I turned on? Yes, can you guys hear me? Yes, thank you. So thank you for the introduction. I'm Laura Jacobsen. I'm a pediatric endocrinologist from the University of Florida in Gainesville. Go Gators, thank you. So I am very excited to come. This is probably my 4th or 5th year coming to CWD. I was a fellow, one of the 2nd class of fellows at Friends for Life. So it's just always been a great experience. I'm happy to talk with you today about work that I do that I'm very passionate about, which is about prevention and reversal of type 1 diabetes. I mostly focus on immune therapies, but I try and cover a little bit of everything here. But again, it's not a very in-depth talk. It's like a broad overview and a where we've been and where we're going. So just a little bit about me. This is how I describe my training. So I did college and medical school at the University of Florida, and then I left for 3 years to do pediatrics training in North Carolina, and then I came back. So I'm almost a Florida lifer, but I was born and raised in Panama City up in the Panhandle. All right, so what we're going to do today is we're going to take a safari through type 1 diabetes interventions, and this is the outline that I have about what we're going to cover today. So it's important to start off with some definitions, why I say certain things, go through where we've been, just to know how difficult it is to try and really interdict in this disease process, and then hopefully where we're going and kind of the latest things that are coming down the pipeline. All right, so some important definitions. So what do I say when I say prevention of type 1 diabetes? So if we're talking about preventing disease, we first have to know who's at risk for that disease. So we've got to screen people. So we can screen people with genetics. So we can do genetic testing to look for those 80+ genes that increase your risk of type 1 diabetes. But that's not quite as specific as doing autoantibody testing. So when we're doing testing for those antibodies that are markers of risk for type 1 diabetes. We usually start by screening relatives because it's a population we have access to, and it's an enriched population. So as you guys know, there's an increased risk of type 1 diabetes once a family member has it. But what we really want to work towards with prevention and screening is we need to screen the whole population. Many of you here may be someone from a family who didn't have a relative with type 1 diabetes when your child was diagnosed. So 85% of people don't have a family history of type 1 diabetes. So we really got to find ways to not just reach family members, but to reach the entire population. So we can find out who's at risk, then we can try different interventions or therapies to try and prevent that progression to type 1 diabetes. And then when we talk about reversal of type 1 diabetes, that's when people have developed type 1 or had type 1 for a long time. How can we work towards insulin independence? But even before insulin independence, we need to talk about ways to improve quality of life. And what we do in the new onset period is we also want to try and prolong that honeymoon period. So you guys may be familiar when you were diagnosed that you had this period of time where things were a little bit easier after diagnosis. Your insulin doses may have come down a little bit. any time you can give to extend that period is actually helpful down the road. So if you think about the honeymoon period, what it's doing is your pancreas is still working a little bit. So you got diagnosed, you had really high blood sugars, you had ketones, some people may have been in DKA. And then once you get that insulin started, so once you start doing self-administered insulin, your pancreas kind of sighs and it has a little break, and then it starts working again for a little while. That helps kind of control blood sugars a little bit easier, and you have a little bit less variability. So if we can prolong that period, it's been shown that people who have a longer honeymoon have less complications down the road. So that is an important aspect of reversing or intervening in type 1 diabetes, aside from just hopefully trying to get free from exogenous or self-administered insulin. I had timing on there, so the optimal time to intervene. I'll show you guys in a little bit why I think those are kind of related to my first 2 points. So we'll come back to kind of the optimal time to intervene in type 1 diabetes. But the keys, I think, and those of us in Gainesville have been working kind of in these 3 areas, mostly focusing on the upper left, is these keys to prevent and reverse type 1. So there are 3 aspects. We have to try and halt that autoimmune attack. So if I just said, I'm going to give you new beta cells right now, you've had diabetes for a year, unfortunately, your immune system is going to attack those new beta cells unless we find a way to stop that autoimmune attack or sufficiently hide those beta cells. So a lot of people are doing really exciting work in the area of hiding beta cells. But also we have to protect the beta cells that people have, right? So people who are at risk for disease or people who've got early disease, we want to make sure that those beta cells they have can stay healthy so we can keep them doing their job. So this kind of is an overlapping thing. When you have long-standing disease, we've got to do this, right? We've got to get all 3 of these areas under control if you've had diabetes for a long time. So not only do we have to stop this autoimmunity, we have to protect the few, but still remaining beta cells. We also need to give you new beta cells somehow. So either regenerate, regrow, transplant, put in, somehow we have to get more beta cells in there. But when we're talking about people who are at risk for type 1 or people who are newly diagnosed, we can just focus on these other 2 areas. We can just work on that autoimmunity, which is mostly what I do with immune therapies, or we can do medications hopefully to protect those beta cells that are still hanging around. So here's just a few, not all, of the kind of areas of therapeutics that are going on in each of these kind of domains. So with autoimmunity, we can give immune therapies that kind of try and tamp down the immune system a little bit so it's not so overreactive. I'll talk a little bit about antigen-specific therapy, so trying to direct our immune therapies a little more closely. And then you'll also see us talk sometimes about cell therapies where we're trying to give a therapeutic to redirect the cells in our body to do something we'd like it to do, not something we are unhappy it's doing. And then islet transplant, beta cell replacement, beta cell differentiation, so taking one cell and making it become a beta cell. And again, those beta cells are the ones that secrete insulin. That's an important area that a lot of scientists are doing great work in, really innovating. And then this one on the bottom, people may not be familiar with, and I apologize for the weird acronyms in there, but ER stands for endoplasmic reticulum. So it's kind of like the protein powerhouse of cells where you're making all these proteins like insulin that then get secreted and do lots of things throughout the body. So it's known that beta cells can get stressed and their endoplasmic reticulums don't work very well. And if it's not under control, then what you can see is eventual death of those beta cells. So there's more than just a white blood cell coming in and attacking that beta cell. Inside the beta cell, there's something going on too. And then the other acronym I have there is UPR. That's the unfolded protein response. So when you think about proteins, you make them and then they get folded into these nice little packages. If any of that process is disrupted, then your beta cells are not as healthy as they should be. The big question is, what happens first? Are these beta cells sick and the immune system comes, or are these the immune system come and then the beta cells get sick? So that's a big kind of paradigm shift over the last several years. So when I talk about timing, it's important to know about timing because people may not realize type 1 diabetes is a big process. So type 1 diabetes doesn't start when you get diagnosed. It starts years and years earlier. So there's often genetic risk factors we can see, but really those autoantibodies and that immune activation starts years before the onset of symptoms of diabetes. And we think it's important for the scientific community and for the community at large to know that that's part of the same disease, and we need to be identifying it, recognizing it, so we can intervene in different steps or stages of this process. So these stages were developed by a group of scientists with JDRF, ADA, and with TrialNet, an international kind of clinical trials consortium that's over in Coronado Q, to develop what we now call the stages of type 1 diabetes. So we think type 1 diabetes starts at stage 1 here on the ribbon. So that's when a person has 2 or more of those autoantibodies, those markers of disease, but they still have blood sugars that are within the normal range. But that could be the start of this kind of change where people are at an increased risk over their lifetime of developing type 1. That can progress to stage 2, where you still have 2 or more of those autoantibodies, and you're starting to get some abnormal glucoses, abnormal sugar. So not to the level that would meet diagnostic criteria for type 1, but kind of this impaired level where you either wake up with a slightly high blood sugar or after eating you have a slightly high blood sugar. And we know that's kind of another step on the progression towards type 1 diabetes. And then we consider stage 3 actual clinical type 1 diabetes, where you present with symptoms, you get diagnosed and often put on insulin at that time. So it's important to know these stages so we can know how to best intervene at what time and which therapies may be effective at each of these times. So I took this figure from a very nice publication. I've kind of listed the authors and the journals down at the bottom there, just some people are interested. So what you can see here on the y-axis, is beta cell function. So think about that as the amount of beta cells or insulin producing cells in your pancreas that are working. And when you first start out, you've got lots of beta cells that are working, and then over time that number decreases and decreases. Even before the onset of type 1 diabetes, before that clinical onset or stage 3, and then you get diagnosed, and then you have that little hump, that little increase in beta cell function. So you see right there. So they call this on here possible partial remission. Another name for partial remission is the honeymoon period that I talked about earlier. So we really want to try and keep that honeymoon period, get it as long as we can, because again, there are long-term benefits of having a prolonged honeymoon period. But we have all these different stages and areas that we can try interventions. All right, so let's start from the beginning. How many people in here were born in 1986? 86? Yeah, me too. So it was the first immune therapy in type 1 diabetes. So they use cyclosporin, something you sometimes see in chemotherapy, transplant patients. And what it did is it did improve endogenous or self insulin production. The problem is this medication kind of wiped out the immune system, so it increases your risk of infection. We don't want that. It also had negative side effects on the kidney. So it was kind of toxic to the kidney. So we were like, that was a nice first try, but we're not very happy with that. So where do we go from there? All right, so I don't want you to think that us in the scientific community are not doing anything. Like, people have been working on this for a long time. This is just like the last 10, 12 years on this slide here. And what it shows is we've tried lots of different ways and lots of different types of therapies to try and interdict in this disease process. So what you can see here, back in 2007, around that time, they started doing stem cells. So we've been working on that for a long time, which is why they're getting really good at it now. You can also see they've done T cell specific drugs. So if you think about the immune system, our immune system tries to get rid of foreign invaders with T cells, kind of think of them as the attacking T cells, and B cells, the cells that kind of alert the immune system, make antibodies, tell other cells what to do. So both of those cells are involved in type 1 diabetes, where they may be dysregulated. Instead of being nice and tolerogenic or happy with the pancreas, somehow they got mad at the pancreas and are attacking that organ instead of what they should be doing. So we've tried T cell specific therapies, B cell specific therapies. There's some vitamin D therapies in there. things that have not been home runs, or you guys would know about them already. There's also been some therapies with different anti-inflammatories, different types of drugs that impact how immune cells are activated. So it's very broad. So people are trying all different kinds of therapies here, and there's a bunch ongoing right now. So I don't want you to think that there haven't been any successes. There have. They're just transient. We haven't had anything that's been a prolonged, sustained impact. So I will go over in a future slide some of the positives we've seen from these immune therapy trials. But before getting to that, these are more kind of broad modulation of the immune system. Is there any way we can get more specific in our reteaching of the immune system? So what I really want to do is target the specific cells that are just attacking the beta cells. Kind of want to leave all the other cells alone. So what we can see is there are these little proteins or antigens in our blood, and they're what bind to our immune cells and tell them where to go. And there are little pieces of beta cell, which are also antigens like these, that somehow get out into the circulation and go train our immune cells to do the wrong thing. All right, so what if I could just find cells that are doing that wrong thing and get rid of them? So that's what antigen-specific therapy is. So this is actually a figure that was made for rheumatoid arthritis. I like to use the field of rheumatoid arthritis as an example because they got lots of medications approved, and we need to be like them and get more medications approved. So in rheumatoid arthritis, they have the B cells, kind of those antibody-making cells. Those are the cells that do a lot of the damage in rheumatoid arthritis. So they used to give medications that kind of wiped out all the B cells. Well, great, that helped, but that causes other side effects. So then they started targeting just those self-reactive B cells and left all the other cells alone. So those are antigen-specific therapies. So we've done that over the last 10 to 15 years. So these are some antigen-specific therapy trials. Instead of using a protein that you would see in rheumatoid arthritis, we use a protein or antigen that you see in type 1 diabetes. So GAD is a common one you'll hear us talk about. So that's glutamic acid decarboxylase. It is one of the antibodies that we test for. And the reason it is because it's a protein in the beta cell. Same thing for insulin, you guys all know, is a big long protein in the beta cell. The problem is the immune system thinks those things are foreign and so is attacking it. But if I can direct a specific immune therapy just to target those immune cells that think insulin is bad, well, that would be great because it could leave the rest of the immune system alone. So we're still working on that because that has very few side effects, right? We're leaving a lot of the immune system be, but it's not been as strong of a response as we see from our more broad therapies. So it's kind of like a balance, right? If you have less risk, you're not going to have as much benefit necessarily. So still working on that. People are finding different ways to give these antigen-specific therapies. Sometimes it can be a pill, sometimes it could be a shot. Sometimes you can inject it right into a lymph node. People are really trying to find ways to deliver these efficiently. All right, so going back a little bit to some biology here. It would be great if all I had to do was figure out how to keep that beta cell alive and tell that, so it's a cytotoxic lymphocyte. So that's what we call a T cell, or a CD8 is the kind of the cell surface marker on it that shows that it's one of those attacking kind of killer T cells. If I could just figure out a way to keep that killer T cell away from that beta cell and keep that beta cell healthy, right? That should be simple. Like, why have we not fixed this problem already? Well, because this is the real problem. Yeah, I like this for like the wow factor when I do that. So there's a lot of steps in how the immune system gets to attack the beta cells. So you have naive or really early T cells that get trained the wrong way. They can become cells that just present antigen to other cells, or they can become those cells that actually directly attack. B cells are also involved in there too. So we got B cells over here. We've got these cells that kind of get activated and tell other cells what to do. Here are those antigen-specific therapies. So we're trying to either teach the gut by an oral medication or the skin with an injection to make more of these regulatory T cells. So these are ones that kind of calm the immune system down, and less of these effector T cells, which really chew up the immune system, if you want to think about it that way. So we've tried those therapies. And then we've tried lots of different categories here, all related to T cells, B cells, different subclasses, even the little tiny cytokines or proteins that these cells secrete that travel through to the next cell. We've tried therapies to inhibit those. And then finally here in the last several years, they are developing these beta cell protective therapies. So therapies that may actually help with that endoplasmic reticulum stress, that protein powerhouse in the beta cell that is actually getting stressed and leading to cell death. There are some therapies that have been developed from other classes of medications that we would never have thought of that are really calming down that anti-inflammatory effect inside the beta cell. So imatinib or Gleevec is a medication they've used in certain forms of cancer. Sitagliptin is a GLP-1. This PPI is proton pump inhibitor, like for reflux. That'd be cool. We put everyone on a reflux medication. I'd be for that. And then Varapamil is another exciting one. This is actually an antihypertensive. So it's a medication for high blood pressure that's been shown to have some effect in kind of regulating this endoplasmic reticulum here and calming down that stress that's going on in the beta cell. I want to leave you with the fact that we have no successes, like I said earlier. So I know these are not very pretty pictures, but I really like to show these at any meeting that I talk at, because these are successful clinical trials with immune therapies in people who are newly diagnosed, so usually within 3 months, with type 1 diabetes. So what you see here is I've got the drug used and what kind of class it is, so a B cell, T cell, or cytokine type of therapy, and which drug it is. I don't name these, I'm so sorry. Like, blame the company. Like, if we had time, we could like pick it, the company, but like, so all these graphs are showing the same things. Let me just tell you what we're looking at here. So this on the y-axis is the amount of C-peptide someone is making. So C-peptide is co-secreted with insulin. It's just more stable and easy to measure than insulin itself. So it is telling us what someone's endogenous in their body insulin production is. We do it as part of what we call a mixed meal tolerance test, where we give people like a boost drink that's got carbs and protein in it. And then we measure over 2 hours how much C-peptide they're making. So it's really showing what their beta cells are doing at that time. On the y-axis here is time. So usually it's 1 year or 2 years, depending on how long the study is. And what you can see is that people in the placebo or control group and people in the treated group, kind of we can do statistics to make them all start off at the same point. And then the natural history of diabetes, as you guys know, when you're diagnosed, is your beta cells keep kind of doing less and less over time. So that's the normal natural history. So you see that in all these bottom lines here. Zoop, zoop, zoop. All right, so that's without any therapy. So that's the placebo group. But then the treated group, they could either have an increase in C-peptide and have this time here where they're making much more than they would have, or a prolonged effect where they're making more than the placebo group, more than the placebo. All here. So these are 6 therapies that we've done trials at that were successful. We said we want to have this much more C-peptide production at 1 or 2 years, and we met that statistically. The problem is, you can see, is that once you stop the drug, or after a certain amount of time has passed from when you got the drug, your C-peptide production goes down. Well, that's not good, right? Like, I could help for a little bit. I could help prolong that honeymoon period, which I think is a benefit, but then we got to keep doing something else. So I'm going to talk about some of the pitfalls of these trials and what we can do as next steps. But these are successful studies that we've had. They're just one administration, or an administration over a set period of time. All right, I'm sure you guys all heard, it's been a couple of years now, so I'm sure this has been presented at multiple, like a couple of Friends for Life ago. But we are really excited that there is one drug that delays the onset of type 1 diabetes. So not prevents, we can't say that people never get type 1, but when you give, so I think, I'm trying to remember how many people were in this trial. So people who were 11 to 22 years old, who had a relative with type 1. So these are the relatives. These relatives have 2 or more of those autoantibodies, those markers, and their glucoses were starting to become abnormal. Not diabetes yet, but starting to become abnormal. Those were the people that enrolled in this trial. and they either got Tiplisumab, that T cell specific therapy, or they got placebo. And they don't know which, because that helps us do better science, because people may alter the behavior if they know which therapy they got. And what we found is people who got Tiplisumab delayed their onset of type 1 diabetes 3 years compared to the placebo group. I think a lot of parents would really appreciate their kid having 3 more years without diabetes, even if you knew you're going to still get diabetes. So 3 years, if you go from 10 to 13, or more importantly, 15 to 18, that would be so helpful, because we know the teenage years, I don't think any of the teens are in here, teenage years are really tough. So this is a very important step in getting this drug approved so that we can give it outside of clinical trials is very important. So I greatly appreciate if any of you that participated in this trial, you helped make this happen. So this is that same kind of figure that I showed before. So C-peptide, nope, not same figure. So this are the percentage of people who were diabetes free. So everyone at the start was diabetes free, so did not have type 1 diabetes. And then by the end, most of the people in the placebo group had developed diabetes, but a lot of people in the treated group had not developed diabetes. And we have that 3-year time lag that we see, which is really important. I think the longest person, the person in the trial the longest, I think they're like 7, maybe up to like 10 years. But like, again, that's one person, whereas some people got diabetes, a year after being in the trial. So it's definitely great that on average, the people who got treated have that 3 years. Some had longer, some had less. All right, so I told you these nice positives, so we can like ride off into the sunset, right? Like, we're done. You guys are all happy. You're not here for any particular reason. No, we still have more work to do. The next step that I think all of you are most excited about are beta cell replacement therapies. Those are really the biggest, I would say, kind of deal breakers that are coming. That is not an area of expertise of mine, but I wanted to share with you what I know about the field and kind of where it is right now. I know there are other speakers here and other papers that are still coming out and companies doing excellent work in this area. All right, so I put together this little timeline. So it does not include everything. It's really just like hit some highlights over the last couple decades. So the first islet transplant was actually done in the 70s. And then since then, they've been getting better and better at islet transplant. So if you guys remember, islets are not just the beta cells, but those little islands that actually have alpha cells that secrete glucagon. They have some other kind of structural membranes and things. All of that little environment helps keep those beta cells that we really care about healthy. So we take these islets and we transplant them, right? So we put them into someone else. The problem is we have to get those islets from somewhere, and then we have to be on immune suppression because that is a foreign organ like a kidney transplant. So you have to be on anti-rejection medications. That is a lot of risk, right? I think most people would say we'd want to avoid that risk unless we really, really needed it. So that's why it's progressed so much over time. The biggest hurdle in the 2000s was people had to use steroids to suppress the immune system. We don't like to use steroids when we can help it in diabetes. If we need to, we need to. But if we're having to be on steroids forever to suppress our immune system, it's not going to help the pancreas very much. So that was a big hurdle that happened 22 years ago. And people who did islet transplants back in the early 2000s had a lot of people who were off insulin for more than 5 years. But those numbers have only increased since then. So now more than half of the people who get islet transplants are off insulin for more than 5 years. Again, those people are on anti-rejection drugs, and those beta cells may not last forever. Sometimes organ transplants don't last forever. You might have to get another one. So these are all things to think about as these therapies continue to develop. The other exciting things is instead of taking a whole pancreas or a whole islet, can we just try and get those beta cells into someone? Can we get them in there in a way that maybe we don't have to give foreign cells? Maybe I could teach a different cell in your body, like a stem cell, which can become lots of different things. Maybe I can teach it to grow into a beta cell. So by giving the right stimulation, maybe we can get a beta cell out of that That would be awesome. So that's what a lot of researchers are doing. The other thing is, if we take beta cells or islets from another person, can we hide them, right? So can we encapsulate them is a common one, or find some other way to cloak them from the immune system. So that's really exciting research being done in several different labs. A lot of that's being done with gene editing, where we go in and we try and edit the part of the genes in our immune system that are attacking those cells that they think are foreign. We're also growing organs in other animals, so trying to grow a pancreas in other animals. That'd be a nice continuous supply of tissue. And then like those stem cells up there, so those are pluripotent stem cells, so that you can give and they last forever, and then they can be induced to grow into different things. All right, so great. We made little baby beta cells. What's happening now with that? So part of the issue we talked about is, one, we have to have a supply of those, right? So there's still pitfalls to this, and we have to be on those anti-rejection medications. So what are some kind of pitfalls in general to these therapies that we're talking about? All right, so part of the reason this is so difficult. When we're talking about immune therapy, so I showed you those six successful trials. You know, we had a year of, year or two of better C-peptide, better insulin production, people who got these immune therapies, but it didn't last. I think all of you guys would be like, well, why haven't you treated people again? I would like to think it's because we're too busy developing other cool things, but it's money, it's time, it's people to do the trials. So if you think about these trials, they take several years. So you've got to have infrastructure to run that. You've got to have money. You got to have the drug company either give us the drug or be a part of the trial. And then you've got to have the system to run it. And we have to have you guys and people you know and other people in the diabetes community be a part of these trials. It's really hard, though, to recruit people when you're newly diagnosed with diabetes. You guys remember when you were first diagnosed? It's really hard to approach people and be like, I know this is a terrible, terrible moment in your life. This is incredibly stressful. Oh, by the way, how about helping the diabetes community at large with this new therapy? It's the 100th thing I've told you today. So it's a real hurdle, but we find ways to approach families and get people to join these trials. And we really appreciate all of you guys who volunteer and do those. It really helps us get these drugs through the trial so that we can get them to the FDA. I want to someday have a list of therapies, and when patient X comes to me, I say, based on looking at you, you should get immune therapy Y. And then they get that at diagnosis, or they get that at a year after diagnosis, or they get that before they're diagnosed because we've screened and found out they have a risk for type 1 diabetes. That is the future. I do not know, in case anyone asks me later, do not know when that's going to happen, because these things all take time. But we are closer to it because of all these trials we've done in the past. So it is moving. What we don't want is to see something not move. The other thing that can be slow is if we try and develop brand new drugs. It takes decades and decades to get a drug that you've never, like a brand new drug that no one's ever seen, get it through animal models, get it into healthy people for the first time, get it into someone with type 1, all the way up to drug is approved. It takes decades. So what we really like to do is take therapeutics from other disciplines. Arthritis is my favorite one to steal therapies from, and use it in type 1 diabetes. There are other autoimmune diseases, like, I'm trying to think what other ones we use. Sometimes Crohn's disease, sometimes arthritis, ones that are altering the immune system or calming down that inflammatory process that we can repurpose, because if they're already approved in other adults, or hopefully approved in children, then we might be able to get that indication for type 1 diabetes even faster. So we really like to repurpose medications from other diseases. You've actually seen us do that with several different ones that I've mentioned here. So anti-thymocyte globulin, or ATG, was one of the therapies that's used in kidney transplant. Abatacept is a medication used in arthritis. Rituximab is used in a lot of different immune diseases, and also sometimes in oncology. We've used these drugs in other areas, and it makes us more friendly to the FDA when we come and say we want to use it in type 1 diabetes. But we also need the companies that make these drugs to get behind us. It is hard. Type 1 is in a weird spot. It is not a rare enough disease that it's like people get that rare disease indication and like a bunch of money goes to it and they can develop drugs just for that small group of people. But it's not so big that the drug company is like, oh, I'm going to make a lot of money off of type 1. So we're in this kind of weird spot with type 1 diabetes where we're kind of fighting for drug companies to keep drugs going forward in type 1 diabetes. So one of those drugs, the one in the bottom right, Golimumab, which is a cytokine inhibitor, that drug worked great. I think it was sub-Q injection, so just under the skin like insulin twice a week, or sorry, every other week for a year or two, preserved C-peptide production. Great, it was a successful trial. Company's not going to carry the drug forward anymore because it doesn't make enough money for them. So we need to leverage drug companies. We need to make our voices heard by these drug companies that there will be a benefit to them, like there will be a benefit to us, the people who treat patients with type 1 or families with type 1, that we need them to keep carrying these drugs forward. All right. And then we talked about those beta cell replacement or regeneration therapies. What are the pitfalls of that? So we talked about limited tissue. So the way we get islets right now for transplant is they're from people who have passed away. So it's like an organ donation process. There's not an unlimited supply of islets out there. So we want to find ways not to depend on cadaveric or organ donor organs for this process. The other thing we talked about is that immune rejection. So we don't want to, I would not want my 7-year-old or a 40-year-old colleague of mine to be on an anti-rejection therapy their whole life, which can increase your risk of infections and death, when we know they've got great technology, but we got to find a better reversal agent than we have right now. So that's what a lot of the exciting stuff going on, where they're encapsulating, trying to hide those beta cells that they're giving. They're also trying to find other ways to shield them from the immune system, like I talked about, trying to change the genome of those cells so that it looks not foreign to the immune system when it gets transplanted. All right, so this is an example I made. Please give me feedback on the quality of these cartoons. What happens often in clinical trials also makes reversing and interdicting in this disease process difficult. So say we have a clinical trial that's starting, and it's going to have drug X. We have these 3 representative people that are going to be in that trial. This is for people who are newly diagnosed with type 1 diabetes. Great. When we tell patients and participants about a clinical trial, we always make sure people know that, you know, a certain number of people are going to be in the placebo group, right? We're not going to get an active drug, but that's how we do the best science. So these 3 people agree. We know one of those people is going to get the placebo. We don't know which until the end, but we know one's going to get the placebo and 2 are going to get the drug. All right. So this is an example. You got these 2 people getting this drug. And this is, we're going to say it's a successful drug. It does preserve beta cell function, at least for a year or 2. Great. So when I show you this next figure, looking at the C-peptide, we should see both of our green and red friends at the top of that curve. So we have this lovely curve here. The problem is, so this is from an actual trial, and we know in blue here, this is the control. So this person who got placebo, we know that their C-peptide was going to go down with time, right? That's the natural history of type 1 diabetes. But these 2 other people with type 1 diabetes, they both got the drug that I told you works. So I know it works because look at this group in red up here. They made more C-peptide. Heck, out to 2 years, they're making almost as much C-peptide as they made when they started. Like, that's awesome. That's like the world's longest honeymoon period right there. So what happened to this green guy here? He got the same drug, but he looks just like the placebo. So why is that? I posit that it's because no 2 people with type 1 are alike. And it makes it really hard to do clinical trials when I'm trying to give 5 to 50-year-olds the same drug. The problem is I won't enroll a trial and get it done in time if I enroll only 7-year-olds, right? Can you imagine me trying to get 100 7-year-olds? But this is part of the difficulty. This is why type 1 is so hard. Within the pancreas of people with type 1 diabetes, there are different immune reactions going on. Basically, some people with type 1 have more T cells invading their beta cell, invading those insulin producing cells. Some people have more B cells. We think we know some of these differences. So people who are younger when they're diagnosed tend to have more of that B cell specific infiltrate into their immune system, and people who are older tend to have more of that T cell. But those are the things we're trying to figure out right now so that someday we can say, well, how do I pick that only people who look like this red guy get the drug, and then people who look like this green guy, let me put them in another trial with drug Y that may be better for them. Because then I would have really great outcomes for this trial and the FDA would be all excited about it. Whereas now we still get a significant result because these people in red do so well. But can you imagine if we didn't have the people down here who also got the drug? I want to help get these people, like get everyone to look like this red guy. See, good cartoons, right? Come on, those are good cartoons. But you don't want to be like this person here who got the drug and don't know why it didn't work. So we're trying to understand from a immune level and from a patient level, what makes these people different so that we can direct them to the right clinical trial. All right, so I think this is the last couple slides. So I listed out here things that I think are kind of the latest and most exciting, things that I'm looking at a lot right now. And since I made this slide, I already got like updates about them that I did not bother changing because I thought I would just tell you. So I talked about that medication up earlier called Varapamil, which is a blood pressure medication. The reason I like it so much is one, we think it's kind of calming down that inflammatory stress in the beta cell, and it's a pill. Super excited to have a pill that may help preserve beta cell function. Do I think this pill will help people come off insulin forever? No, I don't think it's that strong, or we would have already found out are people with type 1 who have high blood pressure. We'd already know that. But I think it can help. If it is like a vitamin you take that helps keep your beta cell healthy and working a little bit while you're still doing your regular diabetes management, that would be excellent, right? It's not that much extra burden and hopefully it could have some benefit. So I'm excited to see where the future trials with Varapamil go and combining it with other medications. Next, I thought this was an interesting case report. So this is one patient. He was a 17-year-old boy who has type 1 diabetes, but he also has another disease. So he has a gain of function mutation in a gene called STAT1. STAT1 affects how your immune cells that help are developed. So we have immune cells that attack, and then we have immune cells that kind of help and tell things to calm down. So those immune cells that help are not working as well. So it can cause rash, fungal infection, diarrhea, but he also had type 1. So it can contribute to autoimmunity. And what they found is a very specific immune medication that affects that pathway. And they gave it to him. So I hate these names, I told you. Ruoxolitinib. I don't know why. And what that therapy did is it helped with the rash, it helped with the diarrhea, and it helped with the autoimmunity in type 1 diabetes. He's been off insulin for a year. Now, do I think that's going to be a prolonged forever thing? Probably not without retreatment, but it really gives us extra hope to look at specific genetics that some people, like the guys in red, maybe that I showed you on the earlier slide, maybe those guys in red have a specific genetic difference or a specific type of immune cell population that we can identify to help push them to the right therapy. Next, you guys probably know more about this than I do because I missed the screening yesterday of the human trial. But ViaCyte, very popular in the news company, developing beta cell replacement. They had a phase 1/2 trial that was already completed that did not have very successful results. They do, however, have this documentary that's just come out talking about one of the clinical trial participants' experience. So their experience with being the first person in the world given this new therapy, right? Someone has to be first. Some people have to try something that's never been given in other people before. So I haven't seen it yet, but I'm looking forward to watching it because it's about the clinical trial process, which is what I do from day to day. They have a new trial that's starting that's looking at not only getting stem cells to become beta cells, but getting those stem cells to be edited, you know what I'm saying? Edited to not be foreign to the immune system. All right, so that's called CRISPR. It's an area where you can like cut out part of the gene, put in the gene you want. So two companies, ViaCyte and CRISPR Therapeutics, are coming together to hopefully be able to get stem cells that are edited and therefore hidden or cloaked from the immune system. So I'm very excited. I think that trial is just starting or about to start. So keep looking for information from ViaCyte. I do like to warn people, I think I have time. Yeah. If you see a headline in the news that sounds too good to be true, it probably is. Please ask your friendly neighborhood endocrinologist to like parse it out for you, or go to the primary paper. I often send a paper to my patients and be like, this is the actual story. So it's not a cure for type 1 diabetes. You'll notice that is the first time I've used the word cure in this talk, because I don't use that word. I think that gives false hope. We are trying to prevent type 1. We are trying to reverse type 1, but it is a long process. There is no timeline or a cure for all that's going to be ready like that. So just, I don't want people to have false hope from news stories. It is great that research is progressing and it needs to be in the news, but we need to take it all with a grain of salt, read the regular, like the paper that it comes from. Vertex is another company I would keep an eye out for. They are also doing stem cells, trying to induce them into beta cells. They, if you've heard them in the news, their first patient, I think, was off insulin. How long was it? Like 3 months after getting the therapy, they were like insulin free. The trial was put on a clinical hold just because when you're doing a phase 1 or first in human trial, the FDA watches you really closely. So I was talking to someone about my talk yesterday and they were like, oh, that clinical hold was lifted 2 days ago. So that's why I didn't update that. So Vertex is now open again and going to finish enrolling the patients for this. So I'm very excited to see these stem cells that are going to become beta cells, how they work in these clinical trial participants. And then finally, the thing I'm most excited about, because again, I do immune therapies, Prevention Bio is who makes Tiplisumab, that drug that delayed the onset of type 1 by 3 years in people who are at risk for type 1 diabetes. That drug has been resubmitted to the FDA, and we are waiting for their re-review of it. The review was supposed to be in August, has now been pushed back to November. So everyone mark November on your calendar for when to look for news about Tiplisumab. See, keep an eye out. I had a fun time picking out these pictures. This is also what I feel like when a CGM goes off, all the moffles do. I'll give this one to Jeff. Okay, so this is my last couple slides here. So what are the scientific community's call to action? All right, so a lot of what makes this difficult in that kind of picture I walked you through with the 3 trial participants is there's a lot of heterogeneity within type 1. That leads to something we're trying to parse out more called endotypes. If you have a certain kind of phenotype about type 1, maybe you would respond better to a specific therapy. That's called an endotype. They do it in asthma all the time. So that's something we're trying to parse out. We need better biomarkers of response. So C-peptide, it's great, but we need other things we can measure to help us know if a drug is working, and then maybe can pivot to another drug if it's not working. So those are things the field is working on. Precision medicine directed enrollment criteria. So this is my big thing as well. Trying to say 6 people come to me wanting to do a trial. I want to pick the people that are going to benefit the most from that trial. Of course, I'd love to have everyone in my trial. I'll get it done faster. But I want the people who are going to have the most benefit be in those trials. So how can I figure out with personalized medicine which of those people it should be? We need big flashy results for the FDA, right? So we got to have like big, huge differences between the placebo group. So that's why we really need people to do trials and then for us to figure out the best people to enroll in trials. We need to combine therapies because, again, I showed you that complex picture of the immune system. We got to attack it from multiple angles, and then we got to retreat with the things that work. What I had for Tiplisumab there at the bottom was actually a glass ceiling. Like, we need some therapy to break the glass ceiling and get approved so that more therapies can come and get approved, and then we can pick, right? Just like you guys can pick what CGM you want, what pump you want based on your life. You and your medical team can help determine which immune therapy or cell therapy works best once we can get some through this glass ceiling. And then, even though none of us always like to partner with pharma, they're how we get things done. So we got to work with them. All right, more animation, look. Not just the scientific community. We all need to be doing these things. This is not just us in the research field or us in the medical field. We all need to be doing this and these extra things as well. So we need to be advocating and supporting each other, which is what this meeting is all about. Participating in research and then working together all aspects of the diabetes community for a diabetes-free world. These are all the people at UF in the Diabetes Institute where I work and in our endocrinology group, and all the people who have supported me and I collaborate with, and I'm happy to take any questions. Thank you. Any questions people want to shout at me? There might be a microphone. Oh yeah, back there.
And when you mentioned stem cells, it's obviously a big part.
Mm-hmm.
Are you specifically talking about embryonic stem cells? And can you sort of?
All right, I'll start over.
Ah.
You mentioned stem cells a lot, and obviously that's a big part of what you guys do. Were you specifically referring to embryonic stem cells or more adult stem cells, both? And what are the, in your opinion today, what are the differences?
Yeah, and again, this is not the difference between adult and embryonic stem cells and not an area of expertise of mine, but people are doing with both. So embryonic stem cells are a little bit easier because they're more immortal. They can last forever. You can do a lot with them. But people are also taking just stem cells that have already been differentiated and trying to get them to turn into other cells. People have also tried to take alpha cells and turn them into beta cells. So I would say both, because I know people do have different concerns about embryonic stem cells. But I think any therapy that advances the cause of type 1 diabetes is worth exploring. So I think both are being used right now by different groups. Way in the back.
In that same vein, are there any studies currently using children who have T1D using their cord blood stem cells or a sibling's cord blood stem cells to create the islets or the beta cells?
Yeah, no, that's a great question.
How can I start one?
What was that? Oh, thank you.
How can I start one?
So there have actually been some studies taking cord blood. So people can bank cord blood, and later, if that child develops type 1 diabetes, people have tried to take that initial cord blood and give it back to the child because that cord blood has nice, calm, healthy, regulatory immune cells. What we've shown is if you just give those cells right back to the patient, they don't do enough. So they're not strong enough. So what people have tried to do, and some people in our lab do, is they try and isolate those regulatory T cells, and can we just grow up that population of regulatory T cells, which is very small, it's like 5% of your immune cells, can we give those back? So we're trying to develop the best practice to increase those regulatory cells. Not if it's your own cord blood, you wouldn't need an immune suppressant for it, but I don't have successful data of cord blood being given back to someone with type 1. They are working on it, but I do not have any successful data to report. Yes. Yeah.
How come there aren't already profiles being created if there aren't for the different
Categories.
like phenotypes of diabetes?
Thank
Like
you.
Patient to patient.
Why don't we already have different like phenotypes and endotypes? One, we don't know all the patients with type 1. I think like oncology does, I think we need a national registry of people with type 1. So I can say, I need 1,000 people with type 1. I want to look at their immune system. I can say that they have this type of T cell and this type of B cell, and this is, I can categorize them. So we just don't have a nice national registry for that. And you've got to have like the time and resources to do sampling. So we are working on doing it with the samples we have, but we don't have like nice big access to everyone with type 1. Yes.
So thank you for your research. And I had a question regarding just a global research coordination, like say the DRI in Miami and other, like, is there a redundancy in some of these? Is there sort of a national like way to organize trials so there isn't redundancy? And you're saying, well, these are the most hard-hitting points. Can you just go on that?
Yes. So trying to organize so we're not like repeating ourselves, and we've got lots of different expertise. Miami has the DRI, Jocelyn, Barbara Davis, all these great institutions that do research and clinical trials. So immune clinical trials are mostly run out of TrialNet. So that's across multiple sites, across multiple universities, and that does clinical trials. Places like the DRI do a lot of transplant, islet transplant, beta cells. We don't do a lot of that at UF. So I think there are some areas that have expertise, and then there are some consortiums like TrialNet or the T1D Exchange, if we're talking about non-drug therapies, that really do help bring everyone together, but we can always do better at talking to our neighbors. Does that help? All right, do we have to, am I being kicked out of the room? Up here first, and then I'll back to you.
Are you familiar with discussion on potential cause due to leaky gut and milk consumption, and or populations that consume primarily a plant-based diet and little to no dairy, having much lower, dramatically lower occurrence of type 1?
I don't know a lot about that. Studies like TEDdy, so that long-term kind of following from birth, have looked at things like that. And it's hard when you look across countries to see those differences. When you try and do different like milk interventions in early childhood, there's not a difference in preventing risk. But what you're kind of saying is over time, our evolution has changed. And I think that change in evolution probably affects our risk of autoimmunity in general. But I don't know a lot about leaky gut and microbiome, and those things are not my area of expertise. So I apologize. I can hook you up with someone to answer that better, probably. Any other last questions back there?
On when the international piece made me think, the countries who have like a universal healthcare system, do they have access to everyone's blood where they can pull that data?
So countries like Germany and the UK have nice national healthcare systems that do have good population level data. They don't necessarily have blood on everybody, but they know when they were diagnosed, what their A1C is. They have a lot of epidemiological data. They also have national healthcare that helps improve clinical outcomes. Sorry I will back off my pulpit now. Thank you guys for joining. I think we have to exit the room.